Respected Chair, honorable delegates, and illustrious participants, my Bangladeshi colleagues, good afternoon. Our earlier session detailed about STC, its processes, modalities, institutionalization, and also the challenges. So what I'm going to do, I'm basically a reproductive health epidemiologist, and I have done reproductive health research and now teaching. So I thought of sharing with you the people that we are talking about triangular cooperation to bring health in them, to bring comfort in them, to let them practice their rights. I'm going to put some face to those issues that we have been talking since morning, and we'll be working on that. So it's almost like introducing alphabets of the language that we'll be talking in terms of reproductive health, in terms of rights, and related issues. So I'm going to take you back a little bit on the ICPD. In the original ICPD program of action, the primary call was universal access to healthcare, including reproductive healthcare, family planning, sexual health. Now the global consensus has been extended a bit further, and what we are seeing, that global consensus is that reproductive health and rights are human rights, and that these are a precondition for women's empowerment, women's equality, which is again a precondition for securing the well-being and prosperity of the people. So we can look at the connections and justify why we are here and why we are talking and why we are talking about the triangular cooperations. This is just an example of the rights we are talking. I'll be giving some Bangladesh examples, but I know that Bangladesh example not unique. It is quite common to the regional situations of women, of rights and other things. So I'm not going to give all the country situation, but wanted to share Bangladesh situation, its success stories, and also the challenges, and also the unfinished agenda. So from the child rights perspective, you can see that the marriage is not permissible until infancy, childhood, adolescence are over, and the person has arrived at adulthood. But what we see today, globally, 82 million girls, 10 to 17, will be married before their 18th birthday. The UN Convention on the Rights of Child establishes that definition child covers everyone until the age 18. And picture shows the contrast. Look at that young girl is being married and taken to her father-in-law's house. This boat we have seen, and this reflects immediately after Cairo conference, the sexual and reproductive ill health. You can look at the spectrum from the younger to the older, and these are the ill health that we deal with. And what is good thing, and that's why we are all here, is that after ICPD, the government's commitment to women's health, to realize their rights, and national level laws, policies, and entitlements for all across the life cycle. And all the 198 countries who are there, they were co-signatories to the program of action book. Let me just share with you that when the chapter 7 was being finalized in PrepCom 3, if you have any of you attended, I was very fortunate person to be the co-chair of that chapter 7 to finalize all the language. So I feel really proud when I talk about ICPD, and it's so close to my heart as the reproductive health is. And you all know that ICPD is definitely an historical icon, and the government's commitment to women's health, realize their rights, national level laws, policies, and entitlement for all across the life cycle. And I feel proud, as I mentioned. And in Bangladesh, what we have done, we have adopted the program of action. Immediately after we came back from Cairo, we started changing our 5-year plan and incorporated the reproductive health package and also shifted the mindset from economics or population economics to public health and human rights. I'm sorry that I'm taking you a little bit back, as I mentioned already. So in Bangladesh, we adopted the ICPD POA, as I mentioned, and also the post-ICPD, we named our program Essential Service Package of Reproductive Health and Child Health. And if you look at the list on the left side, these were all part of the Essential Service Package. These names are very, very familiar to us, like Program of Action of ICPD, Millennium Development Goals, and then in 2010, the POA was revisited by United Nations, and then the Sustainable Development Goal. And Bangladesh has tried its best to put all these goals into its all 5-year plan, and we have tried to accomplish as much as possible. The success of Bangladesh, I would like to share with you that one second, this I mentioned, our Prime Minister was awarded UN MDG Award 2010 for achieving MDGs. We are very close to achieving our maternal mortality targets. We achieved infant mortality targets. And in 50 years of our independence, the maternal mortality ratio has come down from 770 to 173 per 100,000 live births. And we also had 40% decline of the maternal death over a 10-year period. And it is primarily attributable to the fertility reduction and increased CPR, and also increased utilization of health facilities. Bangladesh was also awarded South-South Award of Digital Health and Digital Development. If we look at the contraceptive use in Bangladesh, we will see that there is a 64% contraceptive use among married women of 15 to 49, women of reproductive age, and 55% are using modern contraceptive methods. However, the unmet need also has come down. It is now 10%, which was 12% during 2017 and 18. This is one unique thing that in Bangladesh we have introduced menstrual regulation in 1979. We started a bit early, but formally in the government sector it was introduced in 79, and menstrual regulation has been used in the government setup. Paramedics were trained and they were providing MR under the supervision of the doctors. Also, later on, MRM, medical MR has been introduced, which you know that very effective in terms of unwanted pregnancies, and that has been introduced and were allowed up to 9 weeks after a woman's last menstrual period. I know that India and Nepal is lucky to have abortion legalized, but we do not have abortion legalized, but we have MR available in Bangladesh. I wanted to share some success stories and best practices in Bangladesh. How did we achieve our CPR, contraceptive prevalence rate, that far? During the 52-year span, the total fertility rate of Bangladesh has come down from 6 to 2.3. Now we have 2.3. And at that time, contraceptive prevalence was 8%, and now it is 64%. So that is definitely has a history of how did we achieve that one. And we will see that the female workers visited homes. 37,000 female workers were recruited, and they would go to them. They were called family welfare assistant. They would go home to home, talk to the women, give them the supply they need, and that's why we were able to achieve that one. So there is a doorstep family planning commodities by women to a woman. Another thing that our government created 18,000 community clinics, and each community clinic would serve 6,000 populations. So they were very close to the house of the community where primary healthcare type of services and family planning were offered. There's another element is that we have 7 family planning methods. It's a cafeteria method. And a couple can choose based on his or her situation. So that choice was given to the population, and that definitely is one of the success stories. Also, we have a very good social marketing program of contraceptive, which takes the commodities very close to the home, to the rural community. Even in a small shop, you will find condoms, you will find oral pills. These are very important elements of success. As we are talking of success stories and how do we take to our own countries and learn from another country, these are very important things to look at the success of another country. Let me talk a little bit about the adolescent in Bangladesh. The teenage childbearing has declined 4%, which we are happy because we were getting a bit frustrated. It is not declining. And again, COVID came and that increased. So COVID has made a difference in the early marriage situation in Bangladesh, and I think it's all over the world. However, current BDHS 22, we have found that the 50% girls are married before 18. So still 50% of the adolescents are married before their maturity age. So that we have to still work on that one. Still, we see that 23% of these girls who are married get pregnant with 1 child. We know that adolescent pregnancy are high-risk pregnancy, and mortality is higher. So if we reduce the child marriage, definitely we reduce maternal mortality in that category. Unmet need has come down, I mentioned already. This is just to show that when we talk about adolescent care, adolescent services, adolescent-friendly care, these are not 1 or 2 care. This is the spectrum of care that we have to take it to the adolescent. Married adolescent has a different kind of care. Unmarried adolescent has a different care. These 2 books were designed, printed by the DG Family Planning, and this was sent to the high schools and shared. But I don't think they're doing it anymore. My feeling is that it should continue. This is again a package of adolescent-friendly services. Government is planning to expand, but it takes time because one has to change the cultural perspective of adolescents getting information, getting care, and getting services. When we talk about investment for the adolescents, I know we have session. You see at the bottom a long list of areas where investment has to be done if we want healthy adolescents. And you can see a long list. I'm not going to read it. It's known to all of you. We talk about rights. Look at the type of rights, the number of rights, and the international conventions that keep on making noises about rights and make us commit to the rights. But when we come back to our own country, I think we forget about that. That's what I see in many places. Rights is very difficult to pursue, to implement, and to make sure that the right person has the right of that getting services, getting their care, and the right to survive, right to get services. I'm going to share a few unfinished agenda. I know that people are talking of unfinished business, but I'm talking about unfinished agenda. Still, in most of the countries we are talking here, have gender-based violence throughout the life cycle. From pre-birth, when the baby is in the womb of the mother, there is a violence until the end of last part, elderly abuse of widows. We see that one. This is our Bangladesh Bureau of Statistics report of 2015, where 73% of the women are saying that they have experienced partner violence in their lifetime. So that's still high, very high. When we look at the adolescents, they also have partner violence as well as non-partner violence. And these rates are not acceptable in any country, in any population, not acceptable. We have MR, we have MRM, but still those information are not reaching to the women. Still we have induced abortion rate quite high. And because they are poor, they are resourceful, lack of knowledge, they go to the wrong people, get affected, get complications, get morbidity, and die. Death due to abortion has increased over our last two surveys, 2010 versus 2016. So these are the areas that we have to work more. We cannot relax. Improving access, we all know all of those things. I'm not saying anything. Long time ago, we went to Manila for a conference where we are talking about the provider mindset change, reduce medical barrier. Still, we have to reduce medical barrier. Still, we have to fight for that one. We have to have more training to improve our services so that the services are reaching to the right people at the right time and at the right kind. Sorry, আমার help লাগবে. Sorry, this moved. একটু আসবেন? একটু আসেন এটা। এটা সরে গেছে, I mean, I can put probably. এটা আসবে? দেখেন একটু। I'm almost done. Mr. Chair, I'm almost done. আরেকটু আগাই দিই, আরেকটু আগাই দিই। So I just wanted to share with you the unfinished agenda of ICPD when we look at the government side, so government commitment to women's health. To realize their rights, national level laws and policies. We have everything nicely written in our books, in our policies, but the difference between policy and actual implementation in most of the countries that I have visited, and I see that. Understanding the entitlement of the people that we provide services, that they need services from us. Still, there are unsafe abortion, which is a major public health concern and cause of death among women. Access to improved family planning services to reduce recourse to abortion, knowledge, supply, and everything should reach the right people at the right time. So what should we do? One, definitely the provider's responsibility, but I want to talk about the women, their own responsibility. We have been talking quite a bit about women's agency. We sometimes say that the victims of violence are survivors, but they are not survivors. When we talk about the violence, the early marriage victim, they don't survive. They suffer throughout their whole life. When we talk about early marriage, if a woman has a fistula, she does not survive. She lives with fistula for rest because she do not have money to go and have the fistula repaired. So she lives. She is a victim of violence and suffers throughout her whole life. So these are some of the things we really have to think very carefully. So either women have to shout or we have to shout and have benefit to the women. So I know that the demographic health survey, they have added a question on the women's agency. So we can see that this is an important variable that is coming in front of us. And women has to know, they have to know what are their rights, and they have to know how to claim their rights. And that's so important. And thus my theme is listen to women. They are the ones who are dying. They are the ones who are suffering. And they are the ones serving everyone, the whole family members. Thank you very much.